with the healthcare system. And so I'm really excited to have Amy Stuck and Chris Crowley here today. And yes, please clap because they made this happen. And I'm just going to give you a little information about them. So Chris Crowley is a systems engineer and quantitative analyst with a career dedicated to public health, safety, and well-being. His research interests include healthcare finance, population health, and community-based care, as well as the development and navigation of successful aging throughout the continuum of care. Chris's career at West Health began when it was known as the West Wireless Health Institute. He was blessed to stay on as the Institute shifted to a more fundamental research into healthcare delivery, cost, and successful aging. Chris holds a PhD in electrical engineering from McGill University. Then we also have Amy Stuck. Amy Stuck is Senior Director, Value-Based Acute Care and an Applied Health Services Researcher at the West Health Institute. Amy earned her Bachelor of Science in Nursing from the University of Portland, her master's degree in nursing education from Cal State Dominguez Hills, and a PhD in nursing from the University of San Diego. She completed postdoctoral studies in the Department of Emergency Medicine at the University of California. Her current fields of study include value-based care in Medicare and accountable care organizations, senior-focused acute care, home and community-based innovations, and villages. Amy's over 30 years experience includes acute and critical care nursing, quality improvement, applied research, hospital leadership, and nursing education. So get ready to be wowed, and you two take it away.
So the other really important credential that we have is we are co-founders of Encinitas Village. All we are doing is standing by while our colleagues, whom we introduced earlier, Jesse and Pam, are really just rocking it, and we're kind of just breathlessly standing by watching what happens. As we announced earlier, there's a pilot that just started as we speak. So thank you so much to you guys, and also thanks to the Village Movement California Incubator, because that helped us launch that.
By the way, we did rock, scissors, paper, and Chris lost, so he's giving the presentation.
So let's see, I can just do this. So yesterday we had the privilege of John Zifferblatt, who's our Chief Strategy Officer. He's a physician here. Oh, you can't hear me?
Here, hold it up.
I can. I just ate and I didn't want to finish it off with a microphone. That might make some funny sounds. John Zifferblatt mentioned how much the West Health mission aligns with the mission of villages. So I put both missions up here, but this time what I wanted to do is highlight that there's a couple of small tweaks to the West Health mission that are not currently the mission of villages. So the West Health mission is first and foremost to lower healthcare costs, to enable seniors to successfully age in place with access to high quality, affordable health and support services that preserve and protect their dignity, quality of life, and independence. So you see the overlap, but you also see where West Health is, by its very mission, focusing on healthcare proper. Same success, seniors aging in place, overcoming social isolation, but adding that healthcare component is where we might differ, but that's why we're here. Why are we trying to connect villages to healthcare after all? So it's a must-have to realize the mission. These are exactly the statistics that Patrick put on the Village Movement California website. Just to repeat, because it's staggering, 10.8 million older adults by 2030 will call California home. 25% of the population by 2060. Adults 60 years and older are predicted to be nearly a third of the state's population. And then the really biggie is the 80-plus age group is expected to grow from 2% to about 10%. And what you see in all of these numbers is healthcare needs in California are going to grow. They're going to become more complex. It's kind of the beautiful miracles of modern medicine that people are living longer. But they are living longer with more social complexity, more cognitive challenges, and more chronic disease. So the healthcare needs are growing. And if we want to realize the mission of the villages to advance aging in place, that means we have to embrace healthcare. Healthcare is an enabler of that, and in particular, innovative healthcare at home. Why are we trying to connect villages to healthcare? Well, villages have challenges. If you take kind of the yin-yang of home and community support that villages have, and the kind of the healthcare component, there's a big imbalance. I see some of our colleagues in the incubator from Kern County, and I remember Kern County mentioning challenges that if you go to community-based, say, vendors, businesses, and ask for help to start a village, you're kind of tapped out. This is like get in line behind the Little League, get in line behind the school supplies drive. They're tapped out. On the other hand, in the yin-yang, there's an imbalance. If you look at healthcare, there are some numbers that are just staggering. So U.S. healthcare spending reached $4.5 trillion in 2022. U.S. healthcare spending is more than 4 times U.S. defense spending. As we've been here in the meeting, there's been some pretty high-priced hardware from the Top Gun school that's zoomed by. If you go downtown, you'll see a lot of aircraft carriers. Aircraft carriers cost around $1 million per day when they're not being used. That's just pumping out the villages, keeping the lights on. So it's staggering when you see all of that to contemplate we're spending more than 4 times what we spend on defense on healthcare. And the one that's another kind of staggering statistic is if the U.S. healthcare industry were a country, it would have the 3rd largest GDP in the world at 4.5 trillion. That means the largest economy is the United States, the 2nd largest economy is China, the 3rd largest economy is the United States healthcare industry. So there is a bit of an imbalance where you have villages tapping out local support, trying to do car washes and bake sales, and here you have healthcare, the 3rd largest economy in the world.
And I'll add, because we always share this in all of our talks, is that $4.5 trillion, 1/3 of that, 1/3 is hospital-based care. So a lot of our work is on how do we avoid hospitalization when that's not necessary, and that's why there's a lot of people that are still being hospitalized because it's well paid for that don't really need a hospitalization. That's not the best match for what they need. Hospitals are awesome if they have what you need, but there's a lot of folks that are still getting hospitalized for things that can be cared for in the community.
Great. So the next, again, why are we trying to connect villages to healthcare? Villages hold valuable information, and if I had space, I would have put a $sign because we're talking about value in terms of monetizable value. But the key to that is that healthcare is currently in a tipping point transformation in terms of how it's delivered and how it's paid for. I'm going to jump to the bottom one because that's what's been in the news more recently is Medicare Advantage is a capitated payment model. That means that a typical Medicare Advantage plan like United Healthcare Medicare Advantage, or in some cases a specialty like a clinic-directed Medicare Advantage plan, so a Kaiser Medicare Advantage plan, they get a capitated payment from the Centers for Medicare and Medicaid Services. And the capitated payment means that's all you get. If you have 10,000 members that sign up for a Medicare Advantage plan and the government pays, say, $12,000, the government is paying $120 million to a commercial insurance plan, and that's all you'll ever get. You can't come back for more. The insurance plans, in turn, strike narrow network contracts. Kaiser, of course, strikes a narrow network contract with Kaiser for care delivery for all of the care. This is very different from the traditional Medicare payment model, which is just called a fee-for-service model, where you basically, the people that have Medicare fee-for-service historically got whatever health care was part of the entitlement, and then the bills were paid. That's caused an outwardly growing spiral that's led to those healthcare costs that you saw cited earlier. Medicare Advantage has some nuances that have hit like the front page of the Wall Street Journal. So when we talk about a capitated payment model, it still is risk adjusted, because if you pay a fixed fee for medical coverage without making an adjustment for the intrinsic risk, then the insurance companies will naturally do things to try to bring in the healthiest members and push the unhealthy members aside. So this capitated payment is risk adjusted so that it's a level playing field. You want to have as much incentive to bring older, less healthy members as younger, more vibrant members. Now, there's a lot of dirty tricks they'll do, like come sign up and just walk up to the 6th floor in Manhattan, and there's a lot of tricks like that. But the other one that's most fundamentally controversial now is, how do you know what somebody is going to cost? What's a fair price to pay, given that some are healthier, some are less healthy, some are older, some are younger? There's all of this risk. That's a very controversial topic. But again, just in the spirit of characterizing the tipping point, it's very important that the idea is that there are capitated payments that have risk adjustment. That means predicting how much somebody will cost. Now, the other point is there's 50% Medicare Advantage enrollment. For Medicare fee-for-service, it's not pay-as-you-go, volume-based incentives. So in Medicare, there's legislation, both in the Affordable Care Act and another law called MACRA, that incentivizes value-based care. So you have kind of a leakage of Medicare Advantage type risk payments. In other words, how much is somebody projected to cost? It's not necessarily capitated, but that's a benchmark for value-based care organizations to try to hit or come in below, and then they'll get shared savings. This is a really important point when we talk about the vision for connecting villages to healthcare. Is healthcare, if you look at it from their side, they have a lot of incentives that may not have been there even 10 years ago. It's those incentives that we kind of catch on to and see opportunity in. Of course, the gulf is wide, the devil's in the details, but fundamentally, risk for healthcare cost is being shifted in a very broad brushstrokes way from insurance companies to the providers of healthcare. Profoundly important shift, and it's a profoundly important unrealized opportunity.
Are you guys with Chris? I know it's a lot, and if you don't know a lot about how healthcare is paid for, this can be very confusing, and I had to learn it all from being on the clinical side, where we have blinders onto how things are paid for and having to really learn how things are paid for. So we're going from the McDonald's model, as many times someone drives through the drive-thru they get paid, to actually paying for the value something brings. So that's why a capitated amount, you want to give them a bucket of money and say, you have to meet these quality metrics with this bucket of money. So it's not just, here's a bucket of money, decide who gets care and who doesn't. Remember the 70s with HMOs? You know, we're not rationing care. Quality measures you have to meet, here's your bucket of money, but now you get to do what you want with that. And that's the incentive to keep people well and thriving at home, spending your money that way and being able to keep that money as your revenue, rather than the McDonald's model of just do as many procedures, surgeries, office visits, you know, come see me every 3 months, whether you needed me or not, because that's my revenue stream.
Amy probably has a lot more of these stories than I do, but just to give an example of the types of things that happen in a traditional fee-for-service volume-based care, it's really poignantly heartbreaking. I had a friend whose mother-in-law was really a candidate for hospice care, and somewhere in the care trajectory, that guidance through the system, she ended up having a hip replacement. And her son-in-law asked, why a hip replacement? Is this really appropriate? and the doctor said she's not going to die in the operating room. She died later, but these are grim, like staggeringly troubling stories about how the volume-based healthcare system delivered care, the decisions about what's appropriate. Staggering. I know you have many examples. I wanted to give just a taste because we are really blessed to be able to work in this place, this beautiful setting, but we do have to do some work that justifies having a nice place to work. And so the counterpart to a nice place to work is we have a burden to really dig in deep and do research that nobody else could do, but there's not enough time or resources focused on our mission. So this is a graph that's from a paper that Amy and I just had published in the Journal of Palliative Medicine. And the reason that this is important, I can get into what the bars mean in a sec, is that there are incredibly fundamental limits to predicting on an individual basis who needs what care and when. Remember, risk adjustment is how you make fair prices for a bundle of patients, 10,000 patients, some of whom have 5 chronic diseases, others have none. The risk adjustment is a legacy of insurance where everything happens at a big rolled up level. When you shift that risk over to the providers that have to deliver value, there's a real conundrum, which is you can't predict on an individual level who's going to need what and when.
I like your car insurance example. That always resonated with me when I was trying to understand this concept, is when you think about auto insurance, you know, the auto insurance company knows that if you're 16 to 25 years old and you're a male, you're going to be expensive, but they can't know which 18-year-old is going to get in an accident on which day, right? So that's why they set their rates at those group levels. But when you shift that same actuarial risk onto a provider, you're asking them to predict who's going to get sick next and when and how much is that going to cost you. And so Chris will get more into detail around why that's a problem that we're addressing,
Right.
that we're thinking about.
So I like that this has sort of, it kind of dovetails with what Dr. Cotwall was describing, which is, again, this is in the Journal of Palliative Medicine, but it's basically looking back at healthcare utilization, in particular hospital utilization. So what you have on the bottom, the horizontal axis, are counts of hospital admissions experienced by different cohorts. They are all high-risk palliative medicine type cohorts. So the blue is what is, there's an organization called CAPC, which is the Center
for Advancing Palliative
Care. So that's an organization that's centered in at or affiliated with Mount Sinai in Manhattan. So they have a cohort that are called the seriously ill patients. This is a cohort that's potentially candidate for palliative care. And it's very important when we talk about palliative care to say palliative care is not end-of-life care. Palliative care is quality of life care. It's often confused. But you may have a cohort that has serious illnesses and therefore is the strongest, most viable candidate for palliative care services. So we took the CAPC seriously ill population. It's defined by factors like various diseases, so cancers, chronic diseases like kidney diseases, heart failure, and the like. So this is a high-risk group. Collectively, they experience about 60% of them, let me see, I have to be careful. It's roughly 600 hospitalizations per 1,000 members in a year. So a 60% hospitalization rate, that's a lot. In the general Medicare population, it's probably more like under 30. Under 30%, 300 per 1,000. If you look at this hospitalization rate, it's so important to see how heterogeneous it is. So that blue group, which again is at 600 per 1,000, 65% of them never go to the hospital once. The way you get to 600 per 1,000 is that progressively about 20% go once, about 8% go twice, maybe 4% go 3 times, 2% go 4. This goes out to the 20s. I mean, there are people that go to the hospital 20 and 30 times in a year. That's how you get to that average hospitalization rate. And the risk adjustment payment only speaks to that average. It speaks to more than hospitalizations, but when you get paid capitated amounts, you're getting paid on the expected average for the group. When you're on the provider side, you've got to somehow deal with the fact that 65% don't go at all. If you start throwing resources to prevent them from going to the hospital, they didn't go at all. And then in this study, what we did is say, okay, well, let's try to squeeze down to more seriously ill patients and even most seriously ill patients. So we found more advanced cancers, more advanced kidney disease. If you narrow down what happens, well, this is like whack-a-mole. You still end up with, in the most seriously ill population, 50% don't go. All that happens when you squeeze down to the more and most seriously ill is you get more people that have high counts of hospitalizations. So it's a real conundrum on the provider side. What do? You can't take the risk and just map it over to services. Risk is not the same as medical need, and risk is not the same as medical care. I just wanted to mention that that fits with a lot of anecdotes. Anybody that's familiar with the senior, seriously ill population is, when you hear these stories, like so-and-so, well, where are they? They went out and they went on a zip line. They what? They have, like, they went on a zip line between getting dialysis. Well, yeah, they get help. I mean, somebody helps strap them in, but it's staggering to see, given high risk, who actually squeaks by without going to the hospital once. How did that happen? I can't get through a year without. But that's the nature of risk. Risk is not the same as outcome. I have another funny anecdote. This is one of my favorites. I have a friend who, his mom was old, CHF, COPD, some cognitive impairment, and he was worried. She lives in Boston, he lives here. He called her up and she wasn't answering. He's like, uh-oh, what's going on? Finally she answered. He said, where were you? With a really strong accent, Boston accent. She said, I was out knocking the icicles off the roof. Your father always did that, and since he passed away, I do it. He said, how are you knocking icicles off the roof? She said, well, I go out and I take the walker, and it's just the right just like the icicles. She lived for years and never had. That's not advised, but it underscores risk is not the same as outcome. Now that example is a little bit incongruous with this, because you could say, please don't do that, the roof is fine, put sand, whatever. That would be a very low cost kind of prevent that risk. What you wouldn't do is say, well, she could have fallen and broken hips, so we're gonna go get like a CT scan every month. The question is not whether you put any resources, it's this, most of these resources tend to be expensive. And so providers really need help understanding where and for whom to direct resources. And we can, I mean, that is the setup to the punchline, where that's what villages bring. That's what villages bring is, let me switch this one. Yeah, go ahead.
So can I just do a quick summary so that I know that I understand this? So what you're saying is that there's been this big shift from the risk moving from the insurer to the provider. And can you all hear me? No. Yes. No. Okay. So what you're saying is there's been this big shift where the risk is being moved from the insurance company to the provider. And when providers are trying to manage risk, they're trying to pinpoint exactly when and who they've got to follow, because that's where the money's going to go. If this person has an accident, if this person gets sick, that's how they have to manage their risk. So it's become more like individual specific. And so that's where villages come in, because we know those people. Is that what you're getting at?
Yeah, that's the big hypothesis that we're working on, and I want to emphasize this slide because it's calling out the fundamental limits. There's a great, it's actually buried in a report from the American Society of Actuaries that basically has this tautology that says, if you could tell ahead of time who is going to need what and when, there would be no need for insurance. There would be no insurance industry if you could actually nail who's going to need what and when. It's a fundamental trait of risk. And insurance companies don't care about exactly who. They just pull in all of the premiums, and then as long as they're legitimate, there's the person. I knew somebody would go to the hospital 6 times. I didn't know it was them, but here it is. I will pay out those claims. Healthcare does not necessarily have that luxury. Healthcare needs to understand where and for whom are there emerging needs. Now, nobody's saying that villages can and should take an already incredibly challenging role and add healthcare. And this is where a lot of the research is like a big TBD, is that villages probably can say things like, this person is not themselves. There's a change in status. They're not ambulating. They're not showing up for the checkers matches that we usually have. They're not coming for breakfast. We have a breakfast club and they're not there. The challenge is, if you call a primary care clinic and say, you're their primary care doctor and they didn't come to breakfast, it'll be, well, they can't hang up, but they'll say, if you think this is an emergency, call 911. And then you'll get that revolving door of, okay, well, they weren't feeling well, bring them to the ED, then bring them to the hospital and all of that. So it's a really important point that there's a difference between assuming risk and the nature of risk in a big group and actually nailing who it is. So you actually mentioned it earlier, Kate, the idea of a check engine light. Is villages don't necessarily have to provide a clinical diagnosis. There has to be some type of an escalation of the signaling, but villages know village members to be able to say, I don't know exactly what, I can't put my finger on it, but they're not themselves. If you take absent a village, they end up dehydrated and organ failure, and then in the ICU, the hospitalist will say, well, if I coulda, woulda, shoulda, if I knew they had a tummy bug a week ago, got dehydrated, but here they are in organ failure, I'm gonna try to get them back on track. So it's exactly that, and that I think is one of the big challenges is, what's a bridge too far? Like, villages do know their members, but we can't expect villages to take on more than they do. So I think that there's one more slide that we have.
And can I just add, this is the Amy understanding, is that, if you take on risk for a population of patients, you could, assign all of them a 24-hour nurse, just to make sure that they're okay and you're catching everything early. But that's not financially feasible. You can't do that. So what you need to do is be able to target your high-cost resources where they're needed, and then everything else has to be low-cost or no-cost checking in, right? And so we've got some research projects we're working on where we've got community health workers, certified nursing assistants, home health aides who are in the homes of people caring for them, and they're already being paid for. It's already a job they're doing. Can we just add on a little surveillance where they would have a way to send that signal up to somebody who can sort of investigate it? That's no cost because you're already paying for the home health aide to just give them that extra thing. Villages are already doing what villages do, so that also would be something that would be considered a low cost way of having surveillance over a population of people. And our hypothesis is that providers at risk would support villages to be able to do that low or no cost surveillance of that at-risk population.
If they knew, that's a lot of the work that we're trying to develop, is to more tangibly quantify what's the return on investment. So I'll bring this to the next slide because this kind of dovetails with, if you go to the Village Movement California and look at some of the aspirations moving forward, we know from Kate's introduction, the villages historically proliferate in more affluent communities. And it's an imperative in California, the diversity, the kind of diversity in affluence. To overcome those affluence barriers, there's no reason for villages to not be available to every senior in the state. Villages have a lot to offer the ecosystem, and maybe more so in lower income communities. We don't know that for sure, But there's a lot of plausibility to that argument because it's in the lower affluent communities that you have more social determinants of health, and that kind of really fits in with some of the things that Dr. Jackson was describing, that you have social determinants of health. And it's funny, when Dr. Jackson was speaking, we kind of came to a conclusion, although I don't know what the specific breakdown was, the idea that there are kind of genetic, like choose your parents, there's genetic predispositions, but then there's all of the circumstantial, social, environmental factors. There's a lot of new research, some of it's been done here in San Diego, that shows that your environment interacts with your genetics. There are cardioprotective enzymes that are either suppressed or activated according to how much stress you're under. We all have genes for GLP-1, whether those are expressed. So you really begin to understand the whole person is affected by the environment. In other words, it's not as if we are a predisposed genetic profile, and then depending on what environment we're in, you have some either pluses or minuses to that. This environmental, the environmental and social determinants of health actually map into activating how your genome associates with health. So there's a lot of potentially huge implications of this if we can get some of the baby steps underway. But the brass tacks here is we want to follow the money. We're quite, kind of hardcore about making this happen. We want to follow the money and show that there are things that villages can do that are monetizable by either a Medicare Advantage plan or a provider that's at financial risk, so that this is something that happens everywhere. Villages should not be contingent on people's ability to pay for membership. The membership and the value should be quantifiable to every healthcare system. So somewhere that 4.5 trillion to who knows how, what the number would be. It's more than a 100 to 1, it's probably 1,000 or 10,000 to 1 difference. A little bit of that spillover could actually realize this imperative of value-based care and lower healthcare costs. So with that, I think that we can go to the next slide and basically turn it over to all of the vibrant members here to ask, what have you tried? This is not the first idea. I know that, for example, if we can just call on people, there are some that have some experience. And as we call on you, I just kind of, just as some provocation, consider things like, how do we achieve this vision while still letting villages be villages? We're not trying to transform villages, we're just trying to elicit a little bit of really valuable information and hopefully overcome kind of the affluence barriers. We don't necessarily, and probably would not want to force villages to take on healthcare directly. And then the final just provocation as we open it up for discussion is, how do you kind of honor people's privacy and agency so they benefit from social connections, from overcoming isolation, but not everybody knows what illnesses you have and what procedures. That's a very important kind of balance, that you want that information to find its way to promoting health, but you've got to mind people's business too. And so these are all challenges that I thought we would just open up the floor to discuss. If I could start, Eric's been called upon, he's sort of the star of the show in some cases. But I just wanted to ask, what's your experience? What have you tried? What seems to be a bridge too far? What has worked? How do you see this fitting into this vision that we're trying to work towards?
So my byword that Kate coined early on in this whole weekend is relevance. And how do we maintain relevance as a village? And where's our most relevant position? And if we look at the NORC study that came out of Chicago, University of Chicago, we know that in a few short years, by 2030, many folks in their aging process will not be able to afford the care that they need and the housing that they need and the food that they need. And so as I was looking at that, then how, if that's true, then how would we expect those people to pay a membership fee to join the village? And so where can I place my village to make it relevant to those folks in 5 years from now and in 10 years from now. And so I began to explore options for aligning myself with other organizations. And so early on, I joined the AAA in Sonoma County and got involved with them and doing some research with them and their surveys, et cetera, and then enlisted the hospital to help. And the hospital gave us a great deal of credibility in disseminating these seminars for AAA, surveys for AAA that are done every 4 years. And we collected a lot of surveys and we had a really big success for AAA. I gave the hospital a great deal of credit, and we began to have a relationship now almost 2 years ago with the hospital, and we became friends, the hospital and the village. And that friendship, that relationship has continued to evolve. We're now doing health fairs with the hospital, et cetera. So I saw an opportunity for a grant with the Next 50 organization out of Colorado for an innovation. And so I thought, let's take this opportunity to write a grant proposal for a community resource navigator or a social care navigator, someone who could tell people what services are available in our community, and particularly as they are being discharged from the hospital. So I went to the executive director of the hospital, who is now my friend, because I have helped him accomplish some goals that he needed to accomplish, and we've collaborated on a number of things. I gave him my spiel, and he said, absolutely, do you want to I'll give you a memorandum of understanding? Let's do this. And I said, well, what is this that we're going to do? And so then we worked together to create an outline for how we might begin to discover how a village can work with a hospital. And we now are engaged in starting a 3-year test program to say, what do older people need in Sonoma Valley when they're being discharged from the hospital? Where are the gaps? And of those gaps, what might the village be able to provide? So if I'm being discharged from the hospital from having my knee replaced, I need somebody to take my garbage can out. I need someone to, I need someone to give me a ride home from the hospital. I need someone to pick up my prescription at the pharmacy because I can't get there myself. So there are a number of these kinds of things, and we have yet to determine that. So we created in the first year of our relationship, which begins at 25, we are going to actively seek out what are those things that people need, and then what are those things that the village can provide and still remain a village and not become something different than a village. Then the second phase of this partnership is to then run a pilot program with only a few of the people who are appropriate being discharged from the hospital, so that we can really test this out on a couple of people and learn from it, analyze it, refine our program, tweak it, and then, based on what we've learned and the refinements that we've made and retried, then we can launch the program in the third phase of this, which is now going to be 27, excuse me. So by doing this, we're saying, okay, we're a village, this is what we do, this is how far we can go, these are the needs that the people are experiencing. We can take care of 3, 4, 6, 2 of those needs. We can also direct folks to other organizations that might be able to take care of the others, those other needs, but we're participating with the hospital. So then I took that memorandum of understanding with the hospital, and I'm now using that memorandum to apply for grants locally in town, as well as nationally, because now there are lots of people interested in what is this model of intersection between healthcare and social care. And who are the folks that actually can provide these services? And if we can provide these services without changing who we are, because we're already doing this stuff, we're just maybe extending it to folks that it hasn't been available to yet, and we can figure out those logistics, then we have an opportunity to really change the world here for a lot of folks. And for me, this is very, very exciting work, and the Community Foundation in Sonoma County just is jumping up and down. 9 members of that foundation. They said, don't do a proposal, just write us a paper, give us 1 page, maximum 1 page. Don't waste your time doing a proposal, because we want to fund this. And for 3 years, not just because it's got to be a 3-year at minimum project for us. So they're right, the $4.5 trillion, there's a ton of money out there. We just need to put ourselves in the right place, doing what we do, and being very clear, we don't do what we don't do. We do what we do. Yeah.
Just a quick question though, how do you think about the financial model? So one part is, we had like a 3-month, something like this, not as well thought out years ago. So they fronted a membership for 3 months, and it strikes me that the financial remuneration has to be much greater than the value of a membership to make any sense of it, because you're just perpetuating the model we currently have, which isn't sustainable.
I agree. So her comment was that, how does this work financially? Because the amount of a membership is not sustainable in terms of the
It's not what it costs.
of what it costs. And so that's why I think we have to get
You're trying
outside
to
money.
figure it
We
out.
have to,
Yeah.
yes. And also why I put this such an extended period of time in the planning part of this, so that we can figure out where are the opportunities to bring money in, and so that we can work with the hospital to say, what money do you have to put into this? And so that it's not so specifically tied to this membership piece, so that we can continue to grow this. And there's a lot of questions here that I don't have answers to.
Sure.
But, and maybe more questions than we have answers at the moment. But we've tried to create enough of a runway to give us time to explore those questions and come up with answers as we do it. Crowley?
Maybe this is for both Eric and Chris, and we'll get to when you lift it up, because I'm thinking, okay, how do we get the hospital systems to pay for this versus how do we get philanthropy to pay for this? And so to that end, researchers, actuarial folks, what research questions should they be looking for that healthcare systems would want to know?
So first off, Amy and I are already bickering over who's going to pay for this. She said hospitals aren't going to pay for this.
Hospitals are laying off people right now. They are on such thin margins, still recovering from the pandemic. It's the payers. It's the payers. That's where the money is. And Chris has a different opinion.
No. I did do a back of the envelope, which is, if you have, say you have a village with 1,000 members, and remember that chart we had, they're high risk, so maybe 500 per 1,000 go to the hospital. I hope this works out in real time. So 500 per 1,000, that means we have 500 hospitalizations. High-risk hospitalizations cost a lot. Hospitals pay it's a prospective payment. If you have pneumonia, they'll pay $8,000. If you have pneumonia and you're 85 degrees and have 85 degrees, they're a good paper. If you have advanced age, if you have a lot of other chronic conditions, if you get hospitalized for pneumonia, they pay a lot more. It might be as high as $20,000. So I'm going to put $20,000 just because I can do the math without too much embarrassment. So $20,000 times 500 should be 10 million? Is that-
Yep.
So $10 million in hospitalizations, potentially, very backwards. If you can cut those by 10%, and remember the trick in that is, it's not that you have 500 people out of 1,000 going once. Most of them don't go at all. It's somebody has, like, it's very familiar. Somebody has a cascade, they're doing fine, and then they have the tummy bug, and then they end up with organ failure, and they're hospitalized, and they get discharged, and then something again happens. It's those cascades where your risk has turned into a trigger, and now you're in the revolving door of the ED, the hospital, the nursing home, and it happens over and over again. If you can find those and cut them by 10%, then you're down to, what did we say? You're down to from 10 million, you would be $1 million in savings. Because 10% didn't have that happen. That's kind of, at least, that's kind of like, that's reason. We have evidence, lots of evidence that that can happen.
Katie.
Oh, sorry.
I had a question. So for Eric and for other villages that have tried this, are you considering these, I assume mostly new relationships, or the people who are discharged from the hospitals as potential future members? Are they buying into the village movement? Are they excited to be involved in the village movement? Because it sounds like they're in crisis mode and coming home from the hospital. And so, you know, or is this more like fee for service? You're like, oh good, I get some money to help these people doing similar things I do for my members, but it's totally separate from the members that are wanting to be engaged in your village.
Can I comment on what happened in San Francisco? So we had a relationship with a local hospital, and it was this idea that, Sue, you were talking about earlier, where it was a 90-day free membership to help this person transition to home. And we were enrolling them from a hospital bed. And these are not people that are current members of San Francisco Village, but they're just people that need this kind of support. And the hospital was looking to reduce readmissions. So that was their incentive. Well, it worked for a while, and then the pandemic hit, and then there was all kinds of relationship challenges within the hospital itself. If we didn't get a good handoff from a nurse, then this person was going to be less likely to even talk with our coordinator. So there were lots of built-in obstacles. What we finally did after 4 years was go to the funder, which was Sutter Health, and say, we've learned a lot through this process. One of the major things we've learned is how difficult it is to enroll a new member from a hospital bed. And what we'd like to be able to do is offer social care navigation to all, we have 650 members. We'd like to offer social care navigation to all of our members. So that means post-hospital, pre-hospital, chronic disease management, all different kinds of things, which they said, yeah, great, we'll fund that. So it was more of a hospital community benefit purpose, if you all know what that means. Hospitals that are nonprofit have what's called a community benefit obligation as a nonprofit. They have to give away a certain amount of money to the community, not necessarily their own patients, just to the community. So that's one of the ways to attract that money. But what I've learned through this is that hospitals are not terribly incentivized to keep people out of the hospital. They're incentivized to reduce readmissions because they're going to get financially dinged. But the way they make money is to have people admitted to their hospitals. So I am...
But not readmitted.
Not readmitted, right. So
Especially in 30 days.
So the other question that you were asking earlier, Sue, about this kind of free membership idea, what I'm more interested in is a systemic level relationship.
Yeah.
Where there's an understanding that we represent 10,000 Californians, for example, and we want to talk to a payer. We want to talk to a Medicare Advantage plan.
Yeah, and I just want to be clear about that whether you're talking fee-for-service or a Medicare Advantage plan that's managed by a commercial company, it's all Medicare. It's the money that is coming, has been coming out of our paychecks forever. The payer is Medicare, and that's who we're talking about when you're talking about older adults, whether it's, again, fee-for-service, straight from your doctor's office to a Medicare billing, or whether it's going through a commercial company.
finding out who's incentivized to save money. And so we've started talking about accountable care organizations for that reason, because they're incentivized to keep older people at home, period, right? Off medical claim
And thriving,
and thriving.
because they have to meet quality measures. So
Right.
they have to make sure you're doing okay.
So
And at
tho-
home.
we want to talk to those entities that are incentivized in that way, I would think.
But what about with Crowley and managed care plans that are converting over to providing that long-term service benefit, the home and community-based waivers? Isn't there a play to be made? Because that's not Medicare money, then that's Medi-Cal money.
That's a great point, and we haven't touched on that, but that's, if you are Medicare eligible, but you're also eligible for Medicaid, you are called a dual eligible, and that's a smaller percentage of older adults, but that is a very important group. And to your point, we have done some investigation into CalAIM and that kind of work too, because they obviously are very interested as well. And there's aspects, and Chris, correct me if I'm wrong, but there are aspects of what Medicaid is trying to do in California that would be, I don't want to say in competition of a village, but they're essentially trying to do the same thing that we would be trying to do. Does that make sense?
So you're referring to CalAIM?
Yes.
Yeah, that whole umbrella.
Hi, I'm back from Ashby Village. As I'm sure many of you are seeing, that older vets are having a harder time navigating patient portals to get their health care and navigating telehealth visits, video visits. So our technology volunteers are offering that kind of support. It's a way to, get better health care. And so we're in conversations with Kaiser right now about co-designing a pilot where our members, 50% of whom are Kaiser members, and their members who aren't village members, to see what kind of difference a village makes. And so I'm just kind of curious what you're thinking, because yours is very hospital-based, but we're thinking that joining a village can make a big difference in people's wellness by all the different kinds of service and social connection activities that we offer. So it's kind of more of a global perspective on the benefit of being part of a village.
Right. And who's interested in that? Who's willing to pay for that?
I'm talking to people both on the community benefit side and people that are the Kaiser has so many different
Yeah.
affiliations, but one's on it's not the hospital side, it's the provider side, as you're saying.
I wanted to say, I'm sort of feeling a little bit of the energy in the room. And for me personally, this was really scary, because I didn't know a lot about this, and I didn't feel at all qualified to begin to jump into this what feels like a quagmire. It was really, really over my head. And so I began to do a little bit of research with people who are smarter than me and have done things like this before me to help me. And I believe this is part of what DMC can offer to all of us who are out in the field on the front lines, so that we don't, each of us individually, have to start from scratch to create this model and try to figure this out. And you're talking to somebody who apparently, knows it inside and out, and et cetera, and they don't want to give you the time of day, quite frankly. And so this isn't meant to stun anybody. It's meant to let you know that we're working on this and want you to consider participating and joining us and learning and helping, because the more that we do this together, the easier it will be, and the greater the impact we will have on all of these large organizations, these medical organizations, and the more people we will be able to help collectively together. So, yes.
Thank you very much. And you said you didn't feel qualified. I'm a career healthcare actuary, so I'm not sure that I completely share that. But my question was, You have a PACE program, at least at Escondido. How many villages does your PACE program work with?
None right now. That was our PACE program?
So as far as we know, there are no villages except for Village Encinitas now that is in our PACE program's catchment area. So we are trying to change
Our
that.
only program or PACE programs more broadly?
We need to talk.
Okay.
So we have a PACE program in two PACE programs, one in Sonoma County, one in Napa County. They both service our area. And we have, a PACE program is the program for all-inclusive care for the elderly. And it is they're all-encompassing. They take over everything. They become your primary care physician and service. It's an amazing program. Medicare, Medi-Cal pays for everything. If you are only Medicare, then you have an individual supplement that you have to pay in, and it looks like it's expensive, but I think it's not as expensive as it in comparison to some other costs. But and they provide transportation, daycare, all sorts of things. So the PACE program is a very, very viable option, affordable option for many people who are trying to stay at home, but their needs exceed what their partner can or their caregiver can provide. So it's a great program that we're working with them. We introduced the PACE program to our community, and we had over 200 people show up for a lecture because they wanted to learn what PACE is about. So it's a very hot topic, and if you have a PACE program in your area, catch them, find out what they're doing.
Are they funding you, Eric? The PACE program funding you?
Oh, no. PACE will never fund.
Now, I have access to someone on the national PACE who says that if we provide certain services, that PACE may be able to pay a membership fee and reimburse. He just wanted to show you this.
I think it was 2 years ago, Peter Fitzgerald, who is the executive director of the National PACE Association, spoke at the B2B conference about the connections that are synergistic between PACE programs and villages. So it's definitely on our radar.
He's on my board.
Right.
And I think it's important just to emphasize, I think Eric said this, that we don't expect individual villages to be figuring this out on their own. We want you to know what's happening at the VMC level. And so Carolyn and I have been meeting with Amy and Chris for 18 months now. And we've been working through what's this going to look like and what is a systems level approach that's going to make sense with everybody in mind. So yeah, we're not expecting you to go home and try to establish some relationship with your local payer or hospital, but finding out that we have a healthcare actuarial in the room, this is good news. We would like your name.
I would have been a lot more careful about what I said.
We would like your name and email address, but anybody that is interested in this and wants to contribute to this, we're trying to find a solution at the systems level.
Could I just ask for, while we have the chance to squeeze just a perspective in? Manuel Acevedo has worked a lot. Manuel is, first of all, an instructor in the School of Gerontology at USC, and we've had a couple of really vibrant kind of philosophical discussions about this question I brought up earlier, which is how do you maintain villages, let a village keep its identity, keep people's agency and privacy? Is there any type of pitfall that you see coming down the pike in terms of you're philosophically interrupting villages and kind of shoehorning into something it was never meant to be? So I just wanted to give Manuel a minute to kind of provide that perspective, because it's a really interesting perspective that I had underestimated before talking to him.
Thank you, Chris. So I can only do this from a personal experience point of view. So you might know about my mom, because that was the reason why I joined the village movement. And I'm going to tell you a story about my mom this summer. And as you know, I live here in California. I have two kids. They are 10 and 13 now. And we go see grandma once a year, because she lives in the Canary Islands, Spain. It's a long trip. So we go there for 4 weeks, in August, generally. We went there this summer, and it was great. I go there, and first thing I do is I tell my mom, well, we need to go eat fish, because it's an island, we don't eat fish here for some reason in the US. We go eat fish, and then she ordered something, an octopus actually, and she got some allergy to some of the seafood, really. And we need to go to the doctor, etc. Now, let me tell you, so my mom ages in place for 11 months in the village where she was born. So she's in a village and she has her own life, right? And she has her own pace. But for 1 month in the year, her life is crazy. But the grandkids are in town, right? So suddenly we have the allergy. We go to the doctor. The doctor is gonna take some measurements, right? To measure the height, the blood pressure. The blood pressure is through the roof anyways, because my mom is not sleeping well, she's cooking, she's washing, she's doing all of these things, right? But the doctor, they are trained to make decisions, a medical decision on a very limited amount of data. She comes in, measures the blood pressure, asks 2-3 questions, right? But he doesn't know what's going on in her life, actually. So he does his medical decisions onto a very limited amount of data. What ended up happening is that she's misdiagnosed, basically. She's given some medication, some treatment, and she get a bit of a, it was kind of a beginning of a heart attack, actually. So she ends up in the emergency room, right? While we're there with the family and the grandkids. It's not a surprise, because basically her life is all turned upside down with the kids, the son, and basically the whole thing. And then for me, this is kind of, it's sick, basically, and this is for me the need to connect villages with the healthcare system, is that we need to help the doctors. They're making decisions on very limited amount of data. As you know, right, I'm involved with the village movement. Half of the people in this room are using Healthful Village. So we get to know the villagers because we know the number of social interactions they do. The thing that you mentioned before about the environment, right? Like how often is this person volunteering? How often is this person participating in events? So we can help the medical system telling them, well, we know that this person is not being herself, right now, because there is something odd. Maybe the doctor will make better decisions, and if the doctor makes better decisions, then my mom doesn't need to go to the emergency room. So basically the whole challenge and the whole project and discussion we have with Chris is about how can we make available some of these very valuable information that we have in villages. And we have a ton of data about the number of events this person is participating in, the amount of time they volunteer, the amount of time they request for a volunteer, the amount of time checking how they're feeling. So we know a lot about these members, so if we can bring some of that information to the healthcare system so that they make better decisions, then we're saving a ton of money. So I don't know anything about payers and who's paying for that. All I know is that the villages can help the healthcare system so that people don't go to the emergency room. And that's, basically something we're working on. There's another very interesting aspect, is that we are working, as you know, right, on the technology piece. How can we learn from this data, right? And now there's this very concept that is very important about artificial intelligence, because we could look at the data and detect some behavioral changes, right? If this person used to be very active, participating in all events, and suddenly they're withdrawn, maybe we can send an early alarm system to the medical system so that they don't get sick. Maybe we send them to their primary care doctor and it's just cheaper for everybody. Now, one very philosophical question that we have is that we don't want the machine to take control of your life, right? So we want to do it with you, the village community, so that we decide, okay, we have that data into our software, right, into the database. How do we bring this opportunity to the member? Maybe to the family of the member, right? Maybe to the case manager or the village coordinator, so that they have this early signal, if you allow it, if you think that this is a good use of your data and your privacy, so that we can help you be in better shape and not have any of these medical accidents. So this is a very interesting topic that I'm happy to have with all of you, and it's part of my academic interest and what I do for USC and other things. So we can have this conversation from many perspectives, generally or also technically. But thank you for the opportunity.
Thank you. And I think we have one more question from Bill, and then we'll wrap it up. We'll hit 3 o'clock, and we'll basically buy back all the time that we lost.
Well, part of the difficulty of our healthcare system is that it is so broad. It is literally a hodgepodge lodge. It is made up of a bunch of providers, a bunch of systems that collect money and pass it to the providers. And poor patients are kind of left It's an afterthought, which is unfortunate.
By the way, I'm sorry to interrupt. When it comes to the billing, they are remarkably unified. It
But one of the point I'm trying to make here is that we don't really have a good healthcare system. We have a good sick care system, but we don't have a good healthcare system. We spend a lot more money than most countries on healthcare, and we get less for it than most other countries. So the issue is, how do we right-size that system? And moving some of those dollars from the healthcare system out into the social support system makes a hell of a lot of sense. And it sounds to me like you all are barking up exactly the right tree, or plural trees, in order to do that. The community benefit piece, I think, is a great way to look at this. Hospitals have been getting away with making a lot, but not doing a lot for their communities. So going forward, I think what you need to do, because the system is so multifactorial, how can you find out which villages might be good grounds to do this? Because it's going to depend on how many of your village members are insured by or patients of various hospitals. Finding those linkages and mapping them now, I think, would be helpful. It will certainly be helpful for me, because I can tell you the rest of the country does not have the mature markets that you have here in California. You're a great place to begin looking at these very critical issues. Other markets will mature. Some are maturing faster than others. The DC market is infantile, I think, compared to what you all are doing here. But I think looking at how villages and how people can become more partners with the healthcare system and understand its function so they can move at the appropriate level at the appropriate time in their various diseases is key. And you're on the right path. So I'm glad to see this is happening.
Thank you so much. Thank you, everybody. Thanks for your